Well, let's see. Is it working? Yeah. Hi, everybody. We will begin. The only difficulty is I may have to let some people in. So watch. If I see here a ding, I gotta flip back. Let's see. Okay. Disclaimer. Got in at 4 this morning with traveling and everything. So I'm not responsible necessarily for anything that I particularly say. But so let me start with this. So while I've got your attention, regarding the exam, there were some difficulties with deployment and some of the questions answers. So I have at least two questions that I'll give credit to everybody because one had duplicate answers, and I corrected some that appeared to have been mistakenly marked, and that should have uploaded. But it all is relatively unimportant because not to you obviously, but it's unimportant in the sense that I have to go over each one of these and I will review them to make sure and check everyone's individually on any wrong answers to make sure that they either receive credit appropriately and or if it's one of those ones where I'm not having the question there or anything else that was a glitch, I'll make sure credit is where it's supposed to be. So that's sort of the plan of attack. Then I'll develop a raw score. Let's say there were 60 questions and somebody got 50 of them. That's going to be obviously be a very good grade. And to be fair, and you all could see you can all get a rough idea, I suppose, of your raw score if you go back and look and see what's there and some of the corrections that were made. So you can go from there. But I don't want to entertain questions today about that. I would really just want to get back. I would to do a quick review. I have sent an earlier dictation, which is what I call these on the blood. I do want to do a quick buzz through and just to get everybody a little bit up to speed. I don't want to redo it, and I'll pick up where things happen. So let me go check. That's one of those little dings that I get. I have to go look and see who wants. Somebody wants in. No, we're good. Nobody's asking for permission just yet. Very good. So let's begin and we'll see what we can get done. And then hopefully by Wednesday, everything will be back in order. So I will continue from there. Let's see. Okay. Let me just get started with this. Thank you. Pardon me for just a minute while I do this. There we go. Okay. So this is I had started this is a quick go over. I went over the fact that blood is a connective tissue. All the things here are fairly straightforward. Okay. And we are going to go with regard to the cells. We will look at all of the formed elements in a certain degree of detail, particularly the red cells and the white cells and the platelets. All of those will be looked at. The platelets, certainly toward the very end with blood clotting. The white cells we look at more than once. We look at them in this chapter, sort of basic anatomy, and then perhaps a closer look, particularly when we get to the immune system chapter. And red cells, this is the thorough look here, and that's sort of where we ended up in that previous dictation. And this is a very useful thing to see. I spent a fair amount of time talking about the composition, and this is a very, very famous number, this 55 to 45. This is called the hematocrit, and I'll go into this. And that's the percentage of red cells per volume, and really an important number that's there. The red cells per unit volume tell you is oxygen carrying capability. And it's really a guideline because really that's the job of red cells more than anything else. And from that, sometimes we can almost get an approximation of the hematocrit, which is a similar measure. Okay. And I touched on that as well during it. And then we're going to look at this, the different numbers of white blood cells and generalize a little bit on their roles without and maybe a certain amount of specifics. And certainly look at this aspect of the components of plasma. Just to review, plasma is the liquid portion of the blood in the sense that it's the watery based portion, everything dissolved in water. And proteins, a vast number of proteins dissolve in the water there. We really don't have solids per se. If there's anything that's potentially solid, then the proteins kind of swallow it up and bond to it. And proteins have areas which are fat soluble, the way they fold, from what we used to call, what you might recall remembering is their tertiary configuration. And so you have fat-soluble areas and water-soluble areas that are there. We'll look, I mean, the waste products we'll talk about. We get to that a little bit more when we start talking about, particularly about the urinary tract, dribs and drabs of this. Gases more so in respiratory than anything else. Electrolytes almost continuously as they apply to each of the systems. But the plasma is really all of the components that are dissolved in water and the roles they play. And the proteins are particularly important. And we're going to look at the roles of albumin, globulins, and fibrinogen. And we'll revisit the globulins, particularly in the immune system. That's sort of a background. This is sort of classic. I went over this. This is how we separate blood. We'll talk more about that when we start talking, getting toward the latter portion of this, when we start looking at transfusions, what the blood bank does a little bit with blood, etc. And so this is a sort of a classic way of centrifuge, and we centrifuge it. Formed elements are heavier, plasma is lighter. So when you take it for a spin in a centrifuge, the heavier elements go to the bottom. They would even go down normally, but it just takes too much time. And you can separate them based on that, effectively their density, how heavy they are. And this is a classic example. One of the labs I do, we demonstrate this. Perhaps you'll do something similar to that with Dr. Robbins, hopefully. And that little buffy coat, that's formed elements. That's platelets and white blood cells. And they are much, if you go back and look at the numbers, much less numerous. And here's the red cells. Again, that a fairly consistent number, 45%. Red cells, 55%. Liquid, these are so limited. You can see less than 1%. There's not a whole lot going on with them. A lot of you are going to get universal precautions. I don't want to go into it in a great deal of length. I frankly feel that that's much more relevant when we're talking about micro, and hopefully you'll get it in your micro if you don't have me, but we're going to get that in. We're coming up to that chapter after we finish viruses for those who have me for micro. And the whole idea is hematopoiesis. Basically, this is the bone marrow and where the origination is in the red bone marrow. And there you might recall from bone. Red bone marrow is basically everywhere in the growing from birth all the way probably until we really get to our adult size. And then we have limited areas, but still very productive areas of bone marrow, principally in flat bones. We see a lot in the sternum. We see a lot in the hips, particularly the iliac crest. There's a lot, and we even see a fair amount in the hip and shoulder areas in and around those joints. Okay, there's still an abundance of bone marrow, red bone marrow there. After that, pretty much it's yellow bone marrow. It's there. And they're giving you, and I'm not going to go through all of these, the one that they gave kind of short shift to, and I think there really are two, is particularly this one. We start looking at basically looking from this parent stem cell called hemocytoblast. And you have these two lines. This is something I spent a little time with, again, trying to do this in a relatively quick review fashion. And you can listen to that dictation. We have the myeloid and lymphoid lines. So if you ever hear about leukemia, you have myelogenous and lymphocytic. That's where the two lines. This line has, with the exception, the red cell is sort of the oddball, because what it does is it matures, it gets smaller and sheds its nucleus. We'll look at that separately. The platelets, these large cells are filled with staining granules. So another name that we give, particularly the white blood cells, are the granulocytes. And the platelets, those granules have the clotting factors. And except rather than, we call it a formed element because this doesn't appear to be a cell, it shed its nucleus. These are true cells, they have a nucleus. And these are really just fragments of cytoplasm and membrane. Okay. Where now the lymphoid line are the classic white blood cells, lymphocytes and monocytes, and down the road in immune, again, we spend an inordinately large amount of time. It's really important. So now the red blood cell is basically hemoglobin. Everything else is just, think of it as relatively limited in function. The hemoglobin plays the important part, and whether it is oxygenated or not. The reality is, and I pointed that out, when when your blood is in your veins, it hasn't lost its oxygen. It's lost about a quarter of its oxygen. We have a lot of reserve. And we'll talk about the maturation process down the road and how we look at something called a reticulocyte. What happens is they mature, they lose their organelles. The last, and what we call a reticulocyte is something that we do see in the bloodstream, and about 1% of the red blood cells still have some elements of reticulum. So effectively, you're looking at rough and smooth endoplasmic reticulum that's discernible microscopically, and with modern methods, even more easily discernible by weight and things like that. The way that they use more sophisticated counting techniques in the laboratory today, that's a really important number. So when we look at a retic count, particularly when we start talking a little bit about anemia, and I'll give you some, and that's kind of where we left off, and I wanted to bring you up to that. So they no longer can divide. Basically, they're just a vehicle for carrying oxygen. Okay, with limited ATP they produce through glycolysis because they don't have any more mitochondria. They shed them. It's there. It's a classic biconcave disc that is all about surface area. You can see the massive amount. This is a microliter. It's a millionth of a liter. If you think you have 5 or 6 liters of blood on average, you multiply, that's, so you have roughly, let's say arbitrarily, 5 to 6 million red blood cells per microliter. And then you do the math from there. If you feel like doing it, just to get an idea how many red blood cells you have at any one time. And then more importantly, how much hemoglobin you have. Let me rephrase it. There are 250,000 approximate molecules of hemoglobin in a given red blood cell with 4 spaces to carry oxygen. That's 1 billion oxygens that can be carried each one of those red cells. So you imagine the need of oxygen that we have. You don't have to do the math. You're just going to see 10 to a lot of power with regard to this. And we talked about erythropoietin with its role in the kidney. Okay. And it's basically the kidney. Liver has a limited capability. Again, we probably see more liver in younger than in older. The liver plays a more pivotal role in red blood cell production, let's say in the fetal area, as the kidneys really aren't really that functional. I think the way it is negative feedback. And average lifespan is 120 days. I commented a little bit, and I'll reinforce it when we do the blood. I talked about the nutritional requirements, and I'll look at that again. We look at some slides. You'll see a better set of slides in when I post the second PowerPoint from Marie, because they really show you a little bit more about the maturity, how they get smaller and what's involved. And there's different kinds of anemias that we talk about that are there, and certainly the importance of iron. And this is the whole idea. Anemia is extraordinarily difficult to tolerate, is extraordinarily problematic. I cannot, and we'll get into it when we talk about transfusions and blood. When someone is anemic, and and effectively it could apply to all the blood cells, but typically when you use the term anemia, we're talking about red blood cells. And the most overwhelming symptom is fatigue. And I can't even begin to describe you to the severity of the fatigue. When we're in class, I'll do more talking about it, particularly vis-a-vis transfusions and blood typing and things like that, just to get the severity of it and how impactful it is to someone with it. And sometimes it can be very, very acute when we have a severe traumatic injury, a terrible car crash, gunshot wound, stab wounds, major trauma cases, terrible accidents or terrible things that happen, versus chronic anemia when your just blood gets lower and lower. And most people getting transfusions, it's less so about injuries. It's more about people who are chronic blood loss, I think. They're just showing you how that works. You're going to see that B12 and folic acid are about appropriate development. What's interesting about that, and iron as well. These are all factors, and it's interesting. The anemias are different in that regard. So iron anemia is one factor, but B12 and folic acid are more about development factors. We'll get into that a little bit. And this is kind of where I left it. So I'll backtrack a little bit. the starting point. That took about 15 minutes for me to chat about that. And I appreciate your listening and indulging me because I know I'm not as cogent as I usually am. Let's see. Okay, B12 and folic acid, yes, absorbed from the small intestine. Yes, there's specific kinds of anemia that you'll see in the list. They do play a role in DNA synthesis. Understand, we can't generate folic acid, so effectively it's in the category of a B vitamin as B12. And we'll get into digestive where intrinsic factor plays a role as well, and sort of the systems are linked. Those assist maturity. Remember, red blood cells get smaller as they mature. So when we have not enough B12 and not enough folic acid, one or the other or both, what happens is then we have large red cells. They're so large, we call it a macrocytic, big cell anemia. And proportionally, you don't have enough. If the cell's bigger and you have the same amount of hemoglobin, unfortunately, that lowers its oxygen carrying capability. It's based on something called hemoglobin concentration. So big cells are bad. They're not better, they're worse because they are effectively immature. The flip side of that is iron. The cells are going to mature, but they just can't make enough hemoglobin. So now you'll have a small cell. We call that microcytic anemia. And the problem with a microcytic anemia is the cell is small and it doesn't carry enough hemoglobin just because of its size to take care of oxygen carrying capability. This is much more common. Iron deficiency and typical anemias of that type, where we get small cells and they come from bleeding, it can come through a variety of different factors. There's a variety of diseases that cause red blood cells to not function properly. Certainly, we'll talk about sickle cell and thalassemia, genetic-based diseases, etc. So, typical things. Hemorrhagic is self-explanatory. And understand hemorrhagic bleeding doesn't mean external all the time. Typically, when we bleed externally, it's big trauma. See, you get a cut or a scrape, unless you have an inherent blood problem, it's not going to be a big deal. Whereas internal bleeding is a big problem. We see that particularly with someone like me, and that's my familiarity with it, who had a bleeding ulcer. More than one, but we'll get to that story at a certain amount of length. And what happens that because the difference is you're getting chronic blood loss, and this is not just ulcers. It can be abdominal-based tumors. There's a variety of diseases that can cause this. Autoimmune diseases can cause this. There's a lot of problems that effectively would categorize as hemorrhagic, and really they're very much like, even though you might have enough iron, they're kind of like iron deficiency anemia because you're losing the blood cells, so you don't have enough of them, and so the count is low. Transfusions we'll talk about. That's a classic case. And there's certain infectious diseases that cause hemolytic anemia. So there's certain bacteria, some of their toxins will destroy these that are there. Pernicious anemia, which is particularly B12, it doesn't apply to folic acid. It applies to B12 specifically. That probably has a fair amount to do with dietary things. And by and large, I think the most common are people who, for whatever, have an autoimmune phenomena where they can't make this intrinsic factor. That's produced in your stomach. B12 is only active orally if you make the intrinsic factor. The intrinsic factor and the B12 then are absorbed when you get to the small intestine. If you don't make the intrinsic factor, it's not a terrible problem today because we have B12 injections, we have B12 nasal sprays. Very interesting. So you can supplement B12, and there's nothing wrong with supplementing B12 over there. And again, sometimes it's something I had to do when I talk a little bit more about mine. And certainly when you talk about aplastic anemia, it means all the cells are affected. And the interesting thing, and most of the time, radiation, medications, you can see there's a myriad of things that do this. These are really bad things. I'm sure a bone marrow transplant, you're looking at something that's very past potentially, but almost likely to be fatal. And really what happens there is you lose white blood cells because proportionally you have a fair amount of platelets. So you're losing all the elements. Because you lose white blood cells, you can't fight infection, and that's usually the problem. And here, this is where we see I had a bleeding ulcer, heavy periods, malnourishing because you don't have iron. And again, the hemorrhagic ones are probably in that same category. And then we'll look a little bit about sickle cell and a little bit of thalassemias as well. Those are probably more relevant when we start looking thalassemias, when we look more at uh, certain clotting factor deficiency in the sickle cell. Most people are familiar with that's just a genetic defect in the formation of hemoglobin, and it sickles, loses its shape at low oxygen. I'll talk more about that. And this is the sickling that you can see here. It's here. So what happens at low oxygen? So the misconception is, and we used to think it was straight, what was called autosomal recessive. If both parents were carriers of the disease, there's a 1 in 4 chance that's typical of autosomal recessive for someone to get sickle cell disease. And you can check to see if someone has sickle cell trait. We used to not think that sickle cell trait was a problem. We were wrong. Sickle cell trait in people doing at low oxygen concentration during vigorous sports at elevation, let's say if they're in Denver or Salt Lake City or Mexico City, and you compound that with vigorous physical activity, the trait will cause cells to sickle. If you remember Ryan Clark, and you can't forget him if you watch ESPN because he never shuts up, he was with the Steelers and playing in Denver, and he had sickle cell trait. Everybody's aware of it. He sickled. He lost his spleen. He lost his gallbladder because it clumps up and clots there. He did not have sickle cell disease. He no longer could play in Denver, and the Steelers had a very bad track record with all those playoff games they lost. One of the reasons is they didn't have their starting safety, who was next door to Troy Polamalu. That's part of the problem. So the disease, and there's been a lot of research, and there's lots of things that we can do now that we never could do before, as you can see down here. So there's a lot of promise. There's been a lot of research done, but understand the trait. And there's a lot of terrible things. There was a case down, I think it was at Central Florida, the one in Orlando, and that they had a coach who was one of these hard ass football coaches. Had a player with trait. Thought he was dogging it. He wasn't. Basically started having a run. All of a sudden, he had a sickle cell crisis, even though he had the trait, not the disease. They were aware of the fact he had the trait. He died, and oh boy, I'm not so. The tragedy of someone dying. The legal ramifications are extraordinary. This was some years ago. So moving on. So again, single base mutation, abnormal structure, and all these things. It blocks blood flow into organs, into different areas. It's extraordinarily painful if you did not know that, because it's when you have death of tissue from lack of blood supply, we call it an infarction. If it's in your heart, it's a heart attack. But other organs create tremendous amount of pain. The pain is severe. I have a lot of skin ulcerations. I treated at a big clinic for this when I was still a student down in Richmond, Virginia. And understand, this is a major problem, and the severity of fatigue is certainly there. And here, there's lots of different things that you can go without going crazy through them. There's a lot there. So this takes a look specifically at what happens to red blood cells. They don't have a long lifespan. The typical red blood cell, 120 days, 100 to 120. I've seen different authors, 90 to 120 days about average. That's why blood bank typically keeps your blood for about 6, if you're doing red cells, about 2 months, because it's about, they kind of average out from the time they take it to figure out how much viable cells or useful cells they're going to have if they have to do a transfusion using them. Okay. Oops. And you can see what happened. They lose their elasticity, and the spleen or the liver take over. People rupture their spleens, not just because of sickle cell, because of trauma, the liver can take over that function. It's not desirable. A ruptured spleen that has to be removed is by no means fatal. So ruptured red blood cells are phagocytized by macrophages. So what happens is you have hemoglobin, which is 4 globin chains. Those are polypeptide chains, amino acids basically. We can reuse those. And the heme group. The heme group's the problem. The heme group has iron in it. We can use that. But when we take away the iron from this heme group, this sort of unique molecule that's really just an organic molecule, we get something called biliverdin. And the big trouble with that is we have to get rid of it. That's not recyclable. We can recycle the iron, we can recycle all the globins, but we can't recycle this. And it becomes a very, very famous problem, or rather, toxin's the wrong word, waste product that we have to get rid of called bilirubin. And bilirubin, if you did not know it, gives the color to urine and feces. It's there in different forms, so we have to excrete it. We can excrete it in the urine, we can excrete it in the feces, we typically excrete them in both. And when we can't get rid of it, it backs up into our bloodstream. That's what happens when you have gallstones. That's what happens when you have liver disease like cirrhosis, liver disease like hepatitis. And when it backs up into the bloodstream, it causes a yellowish color, we used to call yellow jaundice. But jaundice means this yellowish color that should manifest itself in certain areas, because once it's in the bloodstream, it spreads forever. So the sclera, the whites of the eye, get a yellowish cast. We see yellowish casts in fingertips and toe tips and things like that. So there's a lot of different areas that are even the individual themselves, their skin manifests it to a certain extent. And so you can see they have to be excreted as these bile pigments, and everything else is recycled. So it damages, it's gobbled up. Again, we use what we can, and we have to get rid of the heme. The iron is available for a lot of different things. Okay. It doesn't mean, and there's problems with iron as well. There's a number of diseases that occur where where cells are being broken down excessively. Sometimes we can't reutilize the iron as efficiency. Iron potentially can be problematic in and of itself, but I don't want to get into. There's diseases called hemochromatosis and hemosiderosis, and that's beyond the scope of the course here. And as you can see, and you'll see a lot of these. This is what it looks like. You have these 2 chains. We call them 2 alphas and 2 beta chains. These are the alphas. These are the betas. And you can see that little disc-like structure they always use. That iron, think of that in the middle, and the heme surrounding it. So here's that iron, Fe. Remember, periodic table. So, and when like I said, when you remove the iron, what are you going to do with this stuff? You got to figure out a way to get rid of it. You don't have to remember the chemistry or anything else like that. I'm not going to ask a bunch of questions about that. I'm not going to go through all of these things. I just want you to understand, more than anything else, okay, what happens? The bilirubin, we can get it into the kidney, we can get it into the digestive tract. You can see what happens with here. So nutrients are absorbed by the small intestine. That's the key area. So B12, folic acid, and iron makes their way in for production. Okay. And when the red blood cells begin to break down, they're gobbled up by either the spleen, okay, or the liver itself, and broken down to their component parts. That's about the size of it. Just here. Now we start to deal with the white blood cells. And again, we revisit this when we're looking at the immune system. That's really their role. And the big deal with white blood cells is they're effectively on guard all the time, and they're not all created equal. You have ones that are better attuned to bacteria. We have ones that are better attuned to viruses. We have ones that are better attuned is the word, more active. Some for bacteria, some for viruses, some for other things. Like it's a whole different ballgame if you're dealing with something like malaria, very, very common infection. And we touch on this, or at least I touched on it in microbe. They have very limited lifespans, and there's a lot of replacement. We're talking about days. Okay. And they're there. And a lot of times their byproducts are continuously available. And so that's a really important number when you're looking at overall wellness, and it's a great indicator for just like like I talked about hematocrit and hemoglobin in the earlier dictation. But that's a quick snapshot into anemia. When you look at white count, and what I'll do, and if I'm on my game, if somebody remind me if I don't do it for Wednesday, we'll do it for Friday. I'll show you some of my old tests. My most recent one's about a year ago, so you get an idea of what the numbers look like. See, I'll approve my HIPAA to release this information to you. So what they do, limited lifespans. They're born in the bone marrow. They don't all mature in the bone marrow. You're going to see that when we start talking about T cells, okay, T cells, the big T stands for thymus. They mature in the thymus. All the other ones mature they're born in the bone marrow and mature in the bone marrow. And the immune system has terminology. I'm just giving you the groundwork. Again, the difference between, and this is the right way to say it, they all have granules. The granules are what they utilize to fight infection or to gobble up invaders, to destroy them, to deactivate them. Think of it any way you want. The question is, are they visible or not? Granulocytes, the granules stain vividly, clearly, and they're visible in different colors with the stains we use. And maybe you've looked at them already in laboratory just because blood cells are easy to see, comparatively speaking, versus agranulocytes. A means without it. People mistakenly think they don't have any granules at all. They just can't see them. They don't stain as vividly. You get sort of a uniform stain. And so you can see neutrophils, eosinophils, and basophils. You got to remember these, and lymphocytes and monocytes. Okay. Hopefully as they move on with this. If not, I will do it later. I'll just tell you now. This is everybody uses the same one because they have a batting order of how many are in the bloodstream, and we'll look at that. That are there. It's actually a funny mnemonic called "Never let monkeys eat bananas." And so you're going to see neutrophils, lymphocytes, monocytes, eosinophils, and basophils. And I'll do that up on the board. And every anatomy textbook probably has that. What's great about red cells can do the same thing. They talk about red cells getting damaged is they can squeeze. Red cells are slippery and they're bendable. They can squeeze through little nooks and crannies. So can white blood cells. Part of what happens in inflammation when you hurt yourself, cells are damaged. They send chemical signals that interact all over your body. And one of the things they do with regard to your bloodstream is basically they make alterations, and white blood cells can do a fancy word called diapedese. They become easily can squeeze through these little openings and capillaries, and the openings are made actually a little bit bigger by these chemicals. And then they will, by way of effectively amoeboid motion, they'll be chemically attracted and sort of scooch their way in large numbers to wherever there's something bad happening. And so they call them cellular adhesion molecules. I don't want to get into CAMs and things like that. What they are, these cellular adhesion molecules, just to simplify it, there's a chemical attraction factor. And by and large, not all, don't want to paint with a broad brush here. In general, the way they do it is they engulf and digest bad guys, pathogens, disease causers. And neutrophils and monocytes are mobile and active, and they're really important. Okay, these are the two players that are fastest ones coming to the scene. That's what we look for. We look for certain kinds of levels of these, and that tells us, and we talk more about this in immune system, as to whether you're in the early stages of fighting an infection or the latter stages. And there's a lot of ways that you can tell. But these are the two big guys. Neutrophils, which are the ones we have the most of, and monocytes, they're very, very active in phagocytosis. So anything that damages cells sets off inflammation. Inflammation is what's supposed to happen. Doctors and clinicians get worried when you don't have inflammation. That means there's a failure in your immune system, and now we're dealing with an interior problem that must be solved, or generally people are going to succumb to it. So The inflammatory response is critical. When the inflammatory response is overly exuberant, it means it's out of control. I mean, you're going to learn that fever is appropriate at certain times. When you twist your ankle and it swells up and gets red and hot, that's fine. Becoming inflamed. If it stays that way, now we have to look and see why it isn't going away. It's going to has to run its course. And so it's designed by accelerating clotting factors, by bringing white blood cells into the area, by sort of walling off the area. You want to think of this way, and increasing circulation to the area, which is how the white cells get there. And you're going to see these basophils contain little granules. Most of the granules are heparin, which means it'll stop the blood temporarily from clotting so the factors can get in there, and histamine, which dilates or widens the blood vessels. So, and that's part of it. Swelling, capillary permeability, let the white cells get there. And because of all the chemicals that are being released and what is going on with all of these things, and the increase in circulation leads to swelling, it leads to heat, it leads to redness, and we talked about this. We call it positive chemotaxis, being attracted to that area. That's white blood cells. So here they are, they're in a capillary. The chemicals make these gaps a little wider. They let the white blood cells sort of more easily attach to the edges and scooch through. And there they go. That's diapedesis. It's like you and I, door will only open part of the way. Somebody parked 2 inches away from you, try to squeeze into your car. That's what that white blood cells do it. And you always see this. So here's the damage. It isn't just the bacteria, just damaging those cells is enough to start it. The fact that there's bacteria and foreign material, and there always will be, okay, creates a significant problem, and then all the things ensue. And we review this again. So, taking a look at some of the specifics about these. Okay, we start with, again, the neutrophils are the most abundant. I'll go over that little mnemonic when we get there. Okay, you've got granulocytes. What neutrophils means they're neutral staining. Okay. The granulocytes themselves, effectively, they call them lilac colored. The stain is basically a combination of vivid red and vivid blue. This is somewhere in the middle. It's neither red nor blue, and they go with the term lilac. So they're staining neutrally. It's like a combination, when I think of it this way, in these acid-base stain. The red is acid, the blue is base. And this is incorrect. Sorry. It's not 2 to 5, it's 3 to 6. So a fancy name for them is polymorphonuclear leukocytes. We sometimes call them polys. And you'll hear those terms. Poly, many, shaped nucleus. And what happens is the nucleus is still a nucleus. Think of it as a sphere. It's just like you've twisted it. Again, think of balloon puppets. Again, twisting and you get a couple of these things, and effectively what they look like. They are the first on the scene for any infection. It doesn't matter whether it's viral or bacterial. Down the road, you're going to see when it's bacterial, this is the abundance. They're very aggressive phagocytically. Normally, we see range between 50 to 70% of all your white blood cells. Normally, in the case of an infection, this number will start to go up. Okay, in an acute infection, you might be getting 85% of these things, particularly if it's a bacterial infection. It wouldn't be the same if that's one of the tells, one of the indicators of bacterial infection. We go over all this once more. Eosinophils are one of the least common. Basophils are the least. Eosinophils are the next. We probably have 1 to 3% of them in all the white blood cells. And the granules are deeply red. They're acidic. The chemical is called eosin. That's the name of the acidic or red color. It has 2 lobes. So you're going to see that, and that's really one of the identifiers, that these granulocytes with the vivid granules, you either have, if it's got more than 2 lobes, like I said, 3 or 6, it's going to be a neutrophil. It's bilobed. We see it raised in allergies. And when they talk about parasitic, it's not just worms. Malaria would be an indicator of this. Very, very much so. People with bad water supply, if they have well water at home, giardiasis or amoebic dysentery, those are protozoan infections. That's something. These are elevated. When they talk about parasite, they're not using a general term. That's generally for, when you get to micro, those are for eukaryotic, not bacteria, not viral infections. When we see eosinophils, and allergies play a role in it. And so that's just part of it. The worm probably is something. And the reason my middle son had eosinophilic disease in his gastrointestinal tract. So he knew it was food allergies from when he was we had this diagnosis when he was a year and a half because he had a lot of trouble digesting things. Doesn't have it so much now. So here you can see 3 lobes. You can see this sort of, they call it, I don't know, it's lilac. Here you can see 2 lobes. Nucleus is blue. Granules are distinctly red. Look at the red blood cells. Look at the white blood cells. White blood cells are bigger than red cells. Okay. And probably those are like little platelets or cellular fragments that are there as well. Basophils are the least abundant, less than 1%. Again, deep blue stain. You almost obscure the nucleus, but it's very, very, very vivid. And a lot of students get them confused under the microscope with lymphocytes. These are like somebody has a whole lot of little blue dots they painted on there. Okay, so you can't see the nucleus. You see them a lot, and these are the thing that really, they play a role in people with severe allergies. These are the culprit when we talk about asthma. These are the culprit when we talk about anaphylactic shock. That's in the immune system, and their size is about the same, and the nuclei are about the same. Monocytes are the largest by far. They are the third. So again, neutrophils are first on the hit parade, most common. We'll do the lymphocytes, they're second. Then monocytes, 3 to 9, 3 to 10, depending on the author. Then eosinophils, then basophils. These are large. They have, it looks like a kidney or U-shaped. I don't think it's bilobed as much as it's indented. We call it an agranulocyte because you can't see the granules. Okay, and so all these others so far, when neutrophils leave the bloodstream, they stay as neutrophils. When eosinophils leave the bloodstream, they stay as eosinophils. When basophils leave the bloodstream, a lot of them become what are called mast, capital M-A-S-T cells. Those are the ones that play a pivotal role in allergies. I'm getting more about that coming in the future. Monocytes, they morph into macrophages. And really, they are there for the long haul. As you can see, they're much longer living. Okay, they stick around longer than the other white blood cells, and they're all there. They're the scavengers. They gobble up debris, dead cells, dead bacteria. You're going to see different kinds of immunological complexes, all the types of things. And when we get to the immune system, we revisit it again. So you can see, here's a basophil, all those little blue dots. Again, bigger than a red cell. But look at the comparison. This is huge. And this is typical. It's more kidney shaped, but it's generally going to have a cutout like that. That's in there. Lymphocytes, second most abundant. Where do we see them elevated inordinately? Viral infections. Somebody got COVID, somebody got influenza. That number is going to go up. Normal numbers between, they say 25 to 33. Typical authors, 20 to 40. They give it a little wider range. They're the smallest. And when you see those on a blood smear, most of the time it happen to be T cells. And that's another lecture too. And what happens with this is the nucleus obscures the cytoplasm. So it appears to have scant cytoplasm, but you're just a big nucleus. And we call it mononuclear forms. The term mononucleosis isn't just about monocytes. It involves them, but more often it involves lymphocytes. Those are mononuclear forms. They're the ones that are affected by the disease mononucleosis that you're certainly familiar with. Okay, T cells and B cells are the big players. Super important for this. We'll get into what T cells do. T cells for thymus, B cells for antibodies. A good way to remember it. They live a long time. So you can see it's just a little bit bigger than a white blood cell and very much of a dark round nucleus, but you can't really see identifiable granules. And we look at the counts. When we see the white count starts to go up, big sign of infection problems. Depends. Our lab back when I was 4.5 to 10.5 to 11, and all of these are, as you can see. And remember, we're talking about millions of red cells as compared to thousands of white cells. We're talking about 1,000 times different red cell to white cell. When it's up, let's say it's 11 or more, we call it leukocytosis. Then you start to explore and you look at which elements are raised, and there's other factors that I'll talk about whether they're mature or immature. And if they're low, then we look at what the problem is. So typically, acute infections, exercise, fluid. I mean, you're dehydrated. Oh, now when you look at this, all of these things start to lower it. Okay, so effectively, this is viral. Typhoid's an oddball. That's more has to do with the toxin. Chickenpox. AIDS would be a better example of this than anything else. Anemia would be a good example. And the differential, and it's easier for me to go over it in class than anything else. And so all of those types of things I'll have to give you. So this gives you sort of broad brushing it. If the lymphs are there, they're elevated, I mean, sure, it could be whooping cough, but I don't think so. I think mononucleosis. Whooping cough is bacterial. The fact is, it's immunological in nature what causes that. I think mono is the best example. EOs, I mean, they're just talking about worms, and those are adequate. I think you'd find other things. Monos, I mean, I ignore this. I say bacterial here, viral here, and we'll get to AIDS in length as time goes on. And to make this the last little note, because we're running out of time, again, cancers in the bone marrow, particularly the white, and typically they manifest themselves in the white blood cells. We'll talk about the red differently. Acute versus chronic. Acute is scary. Chronic is a little bit more manageable. We classify them as they're lymphoid or myelogenous, depending on whether they're in the lymph part or the granulite part. And again, you have large numbers, but because of that, you don't have a sufficient amount of red cells, so fatigue, headache, clotting factors. The fact you have a lot of, they're not functional white blood cells, so infections, pain, all of those, bad blood clotting. And again, you can use a variety of treatments because it is a cancer, bone marrow transplantation, etc. In general, in the elderly, it's a little easier to treat because it's almost always chronic. In children, it's very frequently acute, and that has some big problems. And I think we'll stop it here before we get into the clotting thing. And thank you very much. I'll see everybody hopefully Wednesday back to normal. Thanks for joining in. Appreciate being here. Bye-bye.